Good afternoon. Thank you for joining the Foundation for a Healthy Kentucky's Health for a Change webinar, Assessing Family and Intimate Partner Violence. Let us help you screen and refer. I'm Allie Wells, the Communications Associate at the Foundation. Before we get started, a little bit of housekeeping. We've enabled the live transcript feature on this webinar. You can control whether you see the closed captioning by selecting live transcript on the bottom of your screen. We also invite any questions you may have, just type them in the chat box and we'll address them during the Q&A portion of this program. We are here today to talk about the issue of intimate partner violence, or IPV. Victims of IPV can deal with long-term negative impacts on their ability to heal, improve their situation, and their health. In particular, IPV is a source of adverse childhood experiences, or ACEs, that can impact a child for life. I'm going to tell you a little bit about us. The Foundation for a Healthy Kentucky is a nonpartisan, nonprofit organization focused on healthcare access, tobacco use reduction, obesity, diabetes mitigation, and prevention and child health, specifically preventing and mitigating ACEs. Much of what we do is in the policy realm, whether on the state level, local level, or even school or organizational level. Stop sharing my screen. Joining us today is Dr. Ashley Simons-Rudolph, a research scientist at the Pacific Institute for Research and Evaluation, and JaDora Parks, the Vice President of Programs at the Center for Women and Families. And with that, I am going to turn things over to them.
Thank you so much for having us today. We greatly appreciate it. So we are going to be discussing screening and referring for intimate partner violence, and Ashley is going to pull up a PowerPoint on our screen.
Looks like we're having some technical difficulties. Ashley says she can't hear. JaDora, you can hear me okay, right?
Yes, I can hear you. Let's see. We are so sorry for the technical difficulties.
Oh, there we go.
Okay. The screening for intimate partner violence. Let me tell you a little bit about our services and the project. We've been screening since July of 2021. The primary goal of screening is for us to identify how addressing intimate partner violence can improve survivors' lives. We meet survivors where they are and are able to process that traumatic experiences through psychoeducational groups. We refer appropriate services and recommend them to attend outside community agencies that may be able to help them. And we can quickly screen for intimate partner violence and provide a warm handoff and hopefully a smooth transition from outside agencies to the Center for Women and Families. Allie, can you give me 1 second while I try to pull up the PowerPoint for Ashley because she still cannot hear?
Sure.
I'm so sorry.
Sorry, everyone, just bear with us for 1 second. Ashley, can you try one more time? Can you hear us now? It shows that you're connected to the audio. Awesome. All right, guys, we'll get this going again.
There we go. So to the next slide. Thank you all for being so patient. Technical difficulties. So we talked about the parent program, of course, what the objectives are. Let me talk about what services the Center for Women and Families provides, because a lot of times people only know us in the community as the shelter, but we have so many more services than just the shelter. We have our crisis response crisis line. It's a 24-hour line where individuals can call for safety planning, hospital advocacy. We help them with possibly relocation to another shelter if our shelter is full. We have outpatient domestic violence services, which encompass the parent program, which I will talk about shortly. Court advocacy, we accompany individuals or survivors to court if they have submitted an EPO. We have support groups such as choices groups, and we also have a transitional housing program. We do a lot of prevention work. We are Green Dot trained. Green Dot is an organization that we train high school, middle school, and colleges on how to know the warning signs of IPV. We do professional trainings and community education and awareness. Our sexual assault services, we have a safe clinic at the Center for Women and Families. So if someone has been sexually assaulted, then they can come in lieu of going to the hospital, they can come here to the center where our advocate and a nurse could do the exam on site. We offer counseling and therapy services. We offer shelter as well, legal advocacy, and we have specialized services for sex trafficking. Of course, everybody knows our, go back one slide, please, Ashley, sorry. Of course, everybody knows our shelter, our 24-hour program, which we have case management, and our safe haven program, which if you're an animal lover and you have a fur baby, a lot of survivors do not want to leave their fur babies in that situation. So we have a program where we partner with the Kentucky Humane Society to make sure that the animals are at a temporary foster. And then lastly, the Family Violence Project. The Family Violence Project focuses on young mothers and provides support by empowering them to discuss the impact of violence on their children, how violence has impacted their child's development, and to build parenting skills, to provide a safe place to discuss parenting fears, and have a supportive connection with other people who have experienced intimate partner violence. Actually, next slide. We currently have current partners on that are helping us with this project. We partner with the Family Health Centers, of course, PIRE, Up for Women, Volunteers of America, Scarlet Hope, and the Home of the Innocent.
Hey everybody, I'm Ashley, and I apologize for, something weird. It's everyone's worst nightmare, of course, when you start something up and then like you've planned it and practiced it and then it doesn't go as planned. So thanks for your patience. I am from PIRE, and so now, I want to talk a bit about the benefits of screening and collaboration like this with, with current clients, patients, people that you serve, and the benefits of doing the IPV screening. So, we're looking for ways for people whose primary mission is not IPV, ways in which we can holistically meet the needs of our clients and address them and their holistic health. And one of the things that we found out through our early work is that a lot of providers feel or sense that something's going on in terms of IPV with their clients, and that might be impacting their health or their adherence to medication or their adherence to treatment or anything sort of related to how you are directly serving them. And so, just having a sense, but not being able to directly put your finger on it, and then also not being able to holistically address that issue. And so, by partnering with us and with the Center for Women and Families on this project, it's a way, it's just a warm handoff, an active referral, something that we can more holistically serve the people that we're serving. And also we recognize not everybody's an expert in everything, right? The different topic areas that the foundation does. For example, I really don't know very much about diabetes and diabetic care and prevention. So just as an example, right? And so IPV may not be something that you know a lot about or something that you touch often enough to have have that personal connection. And so, this allows you to make a referral to an organization that has connections in the community and where people are experts in that topic. So why? Well, we know what we do matters. That's why we're in, that's why we're in the work that we're in, right? And so the research on IPV is that women who have talked with their healthcare providers were 4 times more likely to accept IPV-related help when they're offered it. So 4 times more likely. Now we know not everyone is ready for help, but you can increase the chances of that readiness by opening and engaging a conversation with clients that you're already serving and they have trust in you, right? And so, being able to collaborate and say, hey, there's this other community-based organization, they're doing great work, let me help connect you. We also know that women who talk to healthcare providers, and this really goes for any, this particular project was about healthcare providers, but this really goes for any community-based organizations that provide sort of health holistically, 2.6 times more likely to exit an abusive relationship. So those are real people. And what you do and how you connect people with other community-based organizations that are ready and can readily respond really does matter. So many people who experience IPV victimization don't identify what's happening in the relationship as IPV. And this project is not about getting someone to kind of recognize, there could be a lot of things going on, intergenerational violence. This could just be something that's repeated. They might not be able to acknowledge to themselves. They may not be able to articulate where they are. All of that is okay. Where someone is okay. But, this project really approaches this collaboration in a way that doesn't, it's not about naming, it's about connecting people to help that they need. And particularly we know that, sometimes people are not ready to seek services or help for themselves, but they may be ready to seek services or help for their children. And so, their children can be one way in that they can get some help for the sometimes ignored victims of domestic violence. And perhaps later they'll be ready to get help for themselves and they will have built a relationship and they'll have that ready-made relationship and a place to go for help for themselves. The full training that we do, so this is hopefully just to whet your appetite. We want you to come and reach out to us to collaborate. The full training that we'll come and do, it's about an hour and a half. And that includes time for role plays, time for questions. It's very interactive. And the training covers, how to avoid accidentally saying the wrong thing or avoiding stigmatizing language and, things that often could provoke guilt or shame. And so we walk you through, we know that you're experts in serving the clients that you do, and many of the same principles apply to the kind of work that when you're talking about in screening for IPV. And so we can cover some of those in some language that we know works well. So this big page of of a graph here is just to kind of show you overall what it is that we do. How do we screen? You don't have to memorize this. This is just like the big picture if you think about it that way. So we want to get to, is there an issue with IPV? So how can we get to that in the most quick and effective way possible? So we have an initial screener, it's called EHITS, and that's an acronym for something. We go over all of this in the training, but EHITS is only 5 questions. And so we ask these 5 questions to determine whether IPV is a problem for them currently in their lives. And this screener is evidence-based, and it has been shown in the literature to be the quickest way to get to yes, no. Does this person need a referral? Yes, no. Right? Now, if it comes up, yes, IPV is an issue for this particular client, then we can ask more questions to get at what is the impact of IPV on their kids. So we ask the moms, do you have concerns for your child's physical or emotional well-being? Again, knowing that sometimes they don't recognize, they may be trying to manage it on their own and trying so hard to avoid impacting their kids. But we know that violence in the home almost always does impact the kids, right? And so whether she says yes or no, then we go on to ask some questions from a developmental screener. And that is dependent on the age of the oldest child in the household. Again, we cover this in much more detail in the training, but the big picture of what I wanted you to see here is that this is intended to be a brief screener that you can add if you do intake questions, if you have other kinds of case management visits, if you're asking any sort of questions at all. We hope what we would ask you to do is just tack the screener on to those existing questions that you have. You already have your clients, you're building rapport with them, you're already asking them, questions which are sensitive, and just asking some of these questions to get at whether or not they could benefit from some services at CWF. So who does this project screen? Now we know that IPV impacts, unfortunately, virtually everyone across the gender spectrum, with or without kids. And we don't in any way mean to discriminate, but we also know that IPV disproportionately impacts women. And so this particular project, and one of the things with our federal funder, is that this is looking at screening mothers. Mothers who are not accompanied with their partner. So if you're serving both couples, let's say, and both people in the couple, like for a HIV test, and they both come in and get tested at the same time, that would not be an appropriate time to screen. We completely, we'll talk with you about the specifics of your organization and how those visits work and ways in which that you can safely screen folks. So, for example, if the child is there, there's different ways in which you screen if the child is able to cognitively understand what the questions are asking versus if it's a 2-month-old baby, etc. So all of these, this slide is just to make the point that we work with you and tailor the screening process to what will work best for your organization. So how exactly does this partnership work? So, we know that the client is with you, they trust you. You can respond more quickly because you've heard it, they're right there. You've already built rapport with your clients. You may have existing relationships with mental health providers. You may even have an existing relationship with CWF. The value added of this project is that there are processes in place so that you can see, on the other hand, what happens, right? So if you refer someone to services, you can pick up the phone and call somebody like JaDora, or you can email JaDora and she can look and kind of see what's happened. And so that it reduces barriers for the client, but it also reduces barriers for you as you're primarily serving the client. And so it's not like you just send them somewhere or give them a brochure. You get to know and get to work together on what's best for the client. Also, we know that sometimes we screen folks that need immediate services like a safety plan or shelter. And so that's a good way, you know, you already have the number to the line and can help facilitate that a lot more quickly. And there are certain things that are funded by the grant, like the paired program that JaDora talked about. And so you don't have to be a partner with us to refer someone to the paired program, but it's easy when you're a partner with us. And so we just really invite you to join us with this project. I showed you in the graph about the EHITs. And so, you know, I wanted to return to, we're asking you to ask all mothers questions about EHIT stands for extended, hurt, insulted, threatened, or screamed. The E for extended means that it asks one question about sexual violence. If that's positive, so 5 questions of everyone. Typically, providers are telling us it takes about 3 minutes or so to do the screening. If there are signs of IPV, then it's the second question, the child's concerns question, and then either the CDC milestone checklist or the modified Columbia impairment scale. Again, we will go through all of this in the training, but for most of your clients, you know, most people are not currently experiencing IPV. So we're asking you to ask everyone these 5 questions, and then only if there's problems, you would ask additional questions. So here's the screening flow again. It's what we talked about, kind of giving you that big picture. So we wanted to just give you an example of what this might look like. Again, this is a contrived example for one, you know, with the training that you would do with us, we would tailor this exactly to your organization and to your clients and to your preferences. But this is sort of, JaDora and I will do a role play here about just like kind of how this would sound and what it would look like. So we're going to start off at the point of which we have already talked with the client that's sitting in front of us. Let's say they're doing an intake appointment. They're sitting in front of us and they have, we have already talked with them about the screener. We've told them that it's voluntary and they have agreed to be screened. So I will be playing the part of the community-based provider. And I have permission to go ahead and ask these questions about relationship safety. And I also want to point out that in this script, we throw a lot of potential scenarios in there. Typically, this is pretty straightforward, but we just wanted to show you, you know, sometimes we feel like when we're talking about this, people say, well, what if the client says this, or what if they say this? And so we've put some of those frequently asked or like commonly asked concerns in this intentionally. We've put it in this role play. Okay. So, JaDora, you ready?
Ready.
Okay, again, I'm playing the part of the community-based provider, and JaDora is a client. You said you'd like for me to ask the questions verbally. Remember that you can skip any question and you can stop anytime that you want to. Here is a card with the response options for all the questions. Okay? Has your partner ever physically hurt you in the past 12 months? Would you say never, rarely, sometimes, often, or frequently?
No, never.
Okay. Has your partner ever insulted you in the past 12 months? Would you say never, rarely, sometimes, often, or frequently?
He threw a quarter at me in front of all of his friends when I was talking and said, "Here's a quarter, call somebody who cares." It was humiliating.
Oh, I can see that just remembering that brings up some painful feelings. How often would you say that your partner insulted you in the past 12 months? Rarely, sometimes, often, or frequently?
Sometimes he can be so sweet, but he rarely says he loves me. Never mind. This is really nobody's business but mine.
I completely understand. And I really, really thank you for trusting me to tell me about it. The more I know about your situation, the better I can assess how to get some help for you and your children. Is it okay for me to continue with the screener?
Yes.
Okay, thanks. It sounds like your partner can be very sweet sometimes, but sometimes he has insulted you. Has your partner ever threatened or harmed you in the past 12 months? Would you say never, rarely, sometimes, often, or frequently?
You said I can skip any question?
Absolutely. Would you like to skip this one?
Yeah, I don't want to get into this. My friend had CPS knocking on her door the other day, and I don't want any of that happening to me.
No problem at all. You're doing great. My main concern right now is just getting you the help that you need, and I'm only going to have to call CPS under these circumstances. Has your partner ever screamed or cursed at you in the past 12 months? Would you say never, rarely, sometimes, often, or frequently?
Rarely. That's not really his style.
Okay. Well, I know it can be hard to talk about this, but nobody deserves to be screamed or cursed at.
Yeah, I certainly feel like it's really about when he's drinking more than anything I'm doing to make him act like that.
Yeah, you're absolutely right. It's not your fault when somebody behaves that way. Has your partner ever forced you to have sexual activities in the past 12 months? Never, rarely, sometimes, often, or frequently?
Rarely.
Okay. Well, I really appreciate you answering all these questions and your willingness to talk about these behaviors, which I know can be very personal.
Thank you so much for being so nice about it. I could never talk to my friends about all of this.
Okay. And end scene. So again, this is an example of, with a couple of curveballs thrown in, of how this screening can look like. It's something that's intended to be easy for all of your providers to be able to employ. You know, you're already having a conversation with them and to ask. There's a hand card that has the response options for people who are readers. We have a hard copy if the client prefers to read it and fill it out themselves. This is something that we have already piloted with people who are working through a translator for Spanish and for other languages. And so in this case, in this scenario, this person would be defined as someone that we'd want to ask more questions about the potential impact on the kids. And so this person is a person who would likely get a referral to CWF. So just for you to kind of think through, you know, here's an example of a client who, you know, could be screened. So Maria has a 3.5-year-old daughter named Keziah. You know, we know that she's screened positive on EHITS. Then we do the child concerns question, and then we find the age-based appropriate screener. So this right here is from the CDC milestone. Keziah is less than 6 years old, and so you ask these follow-up questions. Again, 5 questions for everybody. You only ask more if there's evidence of IPV, and even the more questions are typically between 5 and 10 questions. So in here, Keziah is 3.5 years old. So you skip to the part of the screener which is between 3 and 4 years old, and then ask these questions. In some cases, like for example, in a clinical setting, you may already know the answers to these questions, and so therefore don't need to ask them. But it kind of depends on the nature of your organization and the other information that you might have. And then JaDora, I know you've already explained the paired program. Do you want to talk to us about the PASS program?
Absolutely. So let me first go to this slide and talk about the results. If a client screens positive for that, or if a client screens negative. So if they're negative, one of the things that we do when we're screening is just to tell them that we're glad that they're safe, that there's nothing, if they need any resources or anything in the future, they're more than welcome to call out, but we call to us. But we want to let them know that it's glad that we can hear that they're safe. If they need any additional resources, let us know. If the screener is positive, we always make sure that we provide them with some reassurance. So we say things like, it sounds like your partner has hurt you, or I'm concerned about your partner forcing you to engage in sexual activity against your will. I'm worried about your safety. Discuss to me about how these concerns affect your children. You can offer to call the crisis line with them, or give them the phone number if you feel like they're at a place where they can take that safely, that information safely. So I do want to point that out. So talking about the PASS program, PASS stands for Parents Acquiring Skills and Strength. And that program is a program that is at the Home of the Innocents. It's similar to the parent program that we offer, but it has a little bit of differences. So we refer clients to the PASS program, as well as Home of the Innocents refers clients to us. And it's a nurturing parent program offered to help with parent education, self-help, support groups for at-risk parents involved with DCS and their children. And the goal is to prevent incidents of child abuse and neglect. The class cycle runs for 12 weeks, and right now they are meeting via Zoom, but they plan to resume in-person groups in the future. So we have introduced our project in the IPV screener. Our information is on this slide. If you want to get involved or you want us to contact you for a follow-up, please put your name or email in the chat, or you're more than welcome to reach out to us via email, and we'll be able to answer any questions that you have.
We hope you will join us. Thanks so much. Back to you, Allie.
You good? Okay. Well, right now we are going to bring Chloe Atwater into the conversation. Chloe is a policy associate at the foundation. She's going to discuss what policies being considered by the state legislature could impact the ACEs and IPV situation in Kentucky.
Thanks, Allie. I'll give you a second to get, yeah, there we go. Excellent. So I just wanted to give you all a brief overview of some of the current bills that are being considered that could have ramifications for those facing IPV. House Bill 7 would add red tape and make it more difficult for low-income families to receive public assistance. This would apply to Supplemental Nutrition Assistance Program, or SNAP, Child Care Assistance Program, or CCAP, and Kentucky Temporary Assistance Program, or KTAP. These programs are crucial for all Kentucky families that need them, but it's particularly crucial to help victims of IPV navigate life after leaving a partner if they do so. And economic stress and belonging to a low-income community are also correlated with IPV. So it's reasonable to think that stripping public assistance from some of the most vulnerable Kentuckians could increase the incidence of IPV. So unfortunately, House Bill 7 is moving along in the General Assembly. It is being heard sometime in the next hour, actually, in the House Standing Committee on Health and Family Services. So please just stay on the lookout for updates and calls to action from the foundation, as well as other advocacy organizations. This has kind of been an all hands on deck effort. Senate Bill 8, I actually just got good news that it passed unanimously in the House Committee on Health and Family Services. So be on the lookout. There will be a big effort from advocacy groups to make sure that this bill passes and becomes law in Kentucky. But it would create a uniform definition of child neglect and abuse, restructure and expand the state child abuse and neglect prevention board. The board would have broad discretion to fund child abuse prevention efforts, counseling for victims of child abuse, and the cost of medical exams necessary to evaluate for child abuse to the extent that exams are not covered by health insurance currently. This includes providing Medicaid reimbursement for exams through child advocacy centers. Every kid in Kentucky has a child advocacy center. And other highlights of the bill include a provision that would broaden the definition of fictive kin. And would grant greater flexibility to youths aging out of commitment to the cabinet. So it's a good bill. A lot of advocates are really excited about it. And let's help get it over the finish line. And a few other bills, we've got House Bill 83. which would bring Kentucky in line with much of the rest of the country and allowing those who are out of work due to IPV to receive unemployment benefits. The bill has not been referred out to a committee, but there was some movement in it Monday of this week when the bill got a first reading in the House Committee on Committees. So in plain terms, it's unclear where the bill is going, and we're seeing kind of contradictory action on it. So if this is something that you would like to see in Kentucky, please can contact House leadership and ask them to assign House Bill 83 to committee. And after I'm done talking, I'm going to read off the legislative message line to you all. And one last bill that I wanted to flag, it's not directly health related, so it's not a bill that the foundation has taken a position on, but Senate Bill 296 would grant Kentucky judges greater latitude in formulating alternative sentencing plans for some custodial parents convicted of nonviolent offenses, which would likely impact a lot of victims of IPV who themselves are often involved in the legal system. That bill has been referred to the Senate Judiciary Committee, but not given a hearing yet. So if this is something that you feel passionately about, you should contact the Senate Judiciary leadership and ask for a hearing on SB 296. And actually, one last note, the Kentucky Senate yesterday overwhelmingly passed SB 271, which will require law enforcement to collect data on IPV. And the bill has been sent to the House, so be on the lookout for that as well. And I will drop the legislative message line phone number in the chat. And in a moment, when we have time for questions, I will be happy to take those.
Awesome. Thank you so much, Chloe. Right now, we are ready to move into our Q&A portion of the program. If there's anything you'd like to ask any of our panelists, just type your questions in the chat box now, and I will read them out. We'll give it just a couple minutes just to see if anyone puts a question in. Right. If there are no questions, and if you have a question later that you think of after this is over, feel free to email any of us and we'll get back to you. Let me share my screen here real quick. Right. So be sure to check out our upcoming Health for a Change webinars. Next month, we're focusing on addressing pharma mental health and suicide. All the information is on our website, healthy-ky.org. And remember, if you can't attend live, be sure to still sign up so we can share you the link to the on-demand video following the training. Be sure to follow us on social media and reach out via email with any questions or ideas for future Health for a Change trainings. And like I said, if you have a question that you think of later, my email's right there. You can email me and I'll make sure it gets to our panelists. And with that, thank you all so much for being here today. We will send you the link for the on-demand video. Feel free to share it with others in your network. Have a good rest of the afternoon. Thank you, everyone.